I'm Elena Call. Nice to meet you, and hello to those of you who are online. Hello to some of my patients that may be watching. Thank you so much, Robin, for the invitation to speak today. Our first talk is focused on the motoric symptoms of the disease for multiple system atrophy. As Robin said, I'm a movement disorder specialist practicing here at Kaiser Santa Clara in Redwood City. So I just want to take you through an outline of the talk this morning. We're going to do a quick overview of MSA and really dive into the motoric symptoms of the disease and talk a little bit about how we make this diagnosis clinically as movement disorder specialists. And then how do we manage these motoric symptoms? And how does the disease progress over time? And then we'll touch on some future directions for research. If at any point you have a question, feel free to raise your hand, but we'll have a Q&A panel at the end as well. Okay, so what is multiple system atrophy? This, as you may know, is a progressive neurodegenerative condition, and it causes many different symptoms, and we're focused on motor at this moment, but the most common umbrellas are that it causes Parkinsonism, ataxia, as well as autonomic derangements, cognitive and psychiatric symptoms. And we're going to go into detail on the motor symptoms, and later in the day, you'll hear much more about autonomic symptoms that come with the disease as well. Pathologically, what's going on is that alpha-synuclein is misfolding and accumulating inappropriately, not in neurons as much, but in supporter cells around neurons. They're called oligodendrocytes. And this is happening in the striatonigral systems of the brain, and then down in the cerebellum and the pons and the olives, which are in the brainstem and cerebellum. We're going to have a picture of that in just a second. This affects between 15,000 to 50,000 Americans, and it affects men and women roughly equally. It's most commonly presenting in the 5th or 6th decade, but unfortunately can sometimes be seen as early in 30s. And the typical progression is on average over 6 to 10 years. So pathologically, multiple system atrophy, I'm not a pathologist, but just wanted to give you an idea of, whoops, sorry. Go back there. Here we go. Don't have layers, that's okay. I will see if you can see my mouse. No. So these are just showing you that alpha-synuclein is accumulating in the cytoplasm of the cells in the oligodendrocytes. And then that brown stain on the right side is showing you a stain on H&E for alpha-synuclein. And then, we're going to talk about in a second that there's two types of MSA. There's a MSAP and MSAC, so a Parkinsonism predominant and a cerebellar predominant phenotype of this disease. And that kind of correlates with what we can see both on gross pathology, these brain slices up here, as well as how the disease actually is spreading throughout the brain. There's some differences that kind of correlate with what we're seeing in patients. So on that top panel, on these two slices of brain, you are seeing a healthy patient that did not have MSA, as well as someone with MSAP and MSAC. And so what they're trying to show you is that there is atrophy here in the striatum. And then here they're showing you marked atrophy of our balance center, the cerebellum. So if you can see on the healthy control is a robust, large cerebellum, is much shrunken down here. And then you see a big fat pons here, and kind of, it's a little more subtle here, but it's kind of flattened. So loss of cells there. And then in this panel, you're looking at MSA Parkinsonism and MSA cerebellar. And it's just trying to show you grossly that as the disease is progressing over time, that we're seeing disease activity kind of really in MSAP more predominantly up here in the striatum, and in MSAC more heavily in the brainstem and cerebellum. So this is how we can account for the great variation that we can see in clinical practice of how patients are presenting. All right, let's dive in. Motor symptoms in MSA. There are a lot, and not all patients get the same thing. So I just want everyone to recognize that. But Parkinsonism is one of the key features in patients who have MSAP, and that consists of slowness, which we call bradykinesia, and that might just be a generalized slowness. And in clinic, your doctor may have you doing finger taps and hand closure and different movements, and it's just like a slowness overall of movement. And then there's changes in tone of the muscles called rigidity, which means that the tone is increased no matter how quickly you're moving. So just increased tone, hard to move no matter what. Some patients have tremor, some people do not. Sometimes there can be that classic pill rolling tremor that we think about for Parkinson's, but it's actually not as common in MSA, but can be. Ataxia can be seen in any patient with MSA, but more common on the MSAC side, and that we'll go into in more detail, but it's by definition an incoordination, and that can affect walking, that can affect fine motor movements and truncal movements. And then dystonia is a problem of involuntary posturing, most common in the neck, and we will talk about that. There can be swallowing problems, changes in speech. There can be stridor of the larynx, which causes a high-pitched inspiratory abnormal noise, changes in posture, gait disturbance, as well as involuntary movements that we call dyskinesia. There's a lot of overlap, though, between the different phenotypes, and there are many patients who, have both cerebellar features and features of Parkinsonism. So it's not always so obvious that, it's just this phenotype. And both share the commonalities of autonomic symptoms, such as orthostatic hypotension, which is a postural change and drop in blood pressure and change in heart rate. Bladder symptoms, including urinary urgency, incontinence, and retention. Erectile dysfunction in men, changes in temperature regulation, severe constipation. So there can be quite a bit of overlap there as well. Dr. Miglis is going to focus more on the autonomic symptoms later today. So just breaking it down so that we're all on the same page. Parkinsonism, like I said, there can be rest tremors, slowness of movements, rigidity. There can be reduction in facial expression. So whereas we normally are smiling and animated, people may start to look like they're almost mad. They're not moving their face. There can be changes in posture, bent forward, tilted to side. I'll talk about some of the gait changes as well in a second. So for ataxia, the most common thing that you might notice with gait is that the patient will widen their base. Instead of a narrow base gait, they may feel unsteady and naturally start to spread their feet apart as they walk. They may slur their speech. It might be more difficult to understand them. They may start to develop as they're moving their hands, kind of ataxia as they're wavering back and forth, or tremors in their hands as they're trying to reach for something or use their hands. As someone watching them, you might notice if they move their eyes that there's beating of the eyes in different directions, which is called nystagmus. These are symptoms that all localize back to that balance center in the back of the head called the cerebellum. And then, as I was saying, dystonia is an involuntary stereotyped abnormal posturing of muscles. And in MSA, the most common area of the body where this will occur is in the neck. And the most common posture that patients will tend to adopt is an anterocollis, where the neck is flexed forward involuntarily. As you can imagine, this can be quite problematic from a pain perspective, from an eating perspective and swallowing perspective, as well as from a speech perspective. We can try to treat this with Botox injections, although I have not found it's quite refractory. It can be very challenging because you also don't want to disrupt and weaken swallowing muscles in the front of the neck. But the anterocollis is the most common, but there are other things that can happen, such as a torticollis, the head turning to one side, or a laterocollis, where the neck is laterally flexed to one side, or a retrocollis, where the neck is pulled back, or a combination of these movements that creates a vector or a tremor. But forward posturing, anterocollis is the most common for MSA. And then swallowing dysfunction, you'll see later when we talk about how we diagnose MSA, typically if swallowing problems are happening early on in the first 3 years of presentation, that's a red flag for us as a neurologist that an atypical form of Parkinsonism may be happening in this patient. And that can start off really mild. It could be, I have patients tell me sometimes, well, I used to be able to swallow 10 pills in one go without water. And I'm like, well, you're an above average swallower. I can't even do that now. Like, and I can't do that now. I'm like, okay. But it could be, you know, that they, some sort of change they're noticing. It could be trouble managing their secretions or kind of just coughing out of nowhere for no reason. Maybe they're having trouble swallowing liquids or solids, choking, like actual choking events or aspiration. There's a lot of ways that patients are trying to tell you that they're having trouble with swallowing. So just keep a broad mind to that. And our wonderful speech therapist, Stevie Shadwick, is going to be talking next, and we'll talk much more in detail about swallowing problems. But I just want to mention that, you know, we really take it for granted. We have like 20 to 30 muscles that orchestrate swallowing, and we don't even think about it normally. But as these diseases are happening, all of a sudden there's a breakdown in this coordination. And it's really important, obviously, that we are working with speech therapists to work on that, which we'll talk about a little later in this talk. And then speech itself, the production of speech can change, and it really varies patient to patient. It can look different. It could be a slurring of speech, a trouble understanding what the patient's saying. It could be that the volume of the speech itself has gone down, or there's a raspiness to the voice. There could be a loss of prosody, like the way we add emotional inflection to the speech. The pitch of the speech could change. In cerebellar patients, there could be scanning. So there's pauses that are abnormal in the speech. There's a lot of different speech changes that you could see in this disease. I actually, in my laryngeal stridor, I'm always looking for this in patients with MSA. I haven't found it as much. It is really important to watch out for. What happens is that the muscles in the larynx, the adductors that are bringing the muscles closer together are actually stronger than abductors. And so what can happen is during inspiration, both during sleep sometimes or during wakefulness, patients will be breathing in, there'll be a high pitched, I'm probably not doing a good job, but a high pitched sound is heard. And we want to be watching for this because we want to direct the patient to ear, nose, and throat if needed for additional support, sleep studies to help diagnose this, because it does carry a worse prognosis if not identified and can lead to morbidity and mortality for this. So posture changes can vary. You know, a stooped posture is common, not necessarily this stooped, but patients can also notice that they're tilting more to either side. Obviously, it can be problematic. We want to work on that with physical therapy. And gait disturbance really varies. It can look really different for each patient. Often, one of the first complaints that patients are making to us is, I don't feel on balance. I am off balance. Maybe I'm almost falling and catching myself. They might be saying, I am dragging my leg along on one side, or just can't get this leg up. They might be noticing they're having trouble starting their gait, which is called akinesia. So they're like standing. It's just, instead of just walking the way we take for granted, they're like standing there, like trying to walk. Or maybe they are walking along and they get stuck on the floor and they're freezing. It's called freezing of gait. They might have that wide base gait, ataxic gait that I was talking about, you know, just needing to respond to the fact that their balance is off by spreading their legs apart. They might scuff the ground, like just not pick up their feet, kind of glued to the floor. They also might have a decreased stride length. So instead of this big normal stride, maybe they're walking like this, where their feet are just taking a really small stride. And then turns can break down. So that would look like, instead of just a nice smooth turn, you know, like we just pivot and take it for granted, you would be taking several steps to complete your turn. We call that an on-block turn. So lots of different changes to the gait can happen. And then finally, another motoric feature of MSA that can lead us into lots of confusion with Parkinson's disease is dyskinesia. These are involuntary movements that are seen with exposure to Sinemet or carbidopa-levodopa, so dopaminergic therapy. They're most common in MSA in the mouth, but they can occur in any part of the body. So just transitioning a little bit, how do neurologists and movement disorder specialists make this diagnosis of multiple system atrophy? It's actually quite complex. And so believe it or not, we are still using expert consensus criteria to make the diagnosis. That the last update was by the Movement Disorder Society. That's our international experts in movement disorders. And this was just 2 years ago. So the experts in the whole world sit down together, like, 20 or 30 of them, and they, debate for 5 or 6 days. What are our criteria? How can we make them as specific for this disease and as sensitive? And how can we do the best to send this out to all of our practicing colleagues to make this diagnosis? This may sound really inadequate. We are moving toward hopefully more biomarker-based diagnosis, and it's all evolving like right in front of us right now, which is really exciting. And as you might imagine, this can lead to challenges in the clinic. There's a lot of overlap between this disease and Parkinson's disease, other forms of atypical Parkinsonism. And I know because of the system I work in, I work with 25 different general neurologists that refer into me, like, MSA cerebellar presentation. Oftentimes these patients have gone down long rabbit hole workups looking for spinocerebellar ataxias, acquired causes of ataxia. It can really be challenging sometimes. Sometimes it's really easy. It's really obvious to make this diagnosis, but it's not always. So what are the current recommendations of how we make this diagnosis? Well, I've oversimplified this because these expert criteria really look at different levels of certainty. You can't officially make a diagnosis without tissue, which is after a patient has passed away. But in patients that are living, these are the most strict. So like this is the highest level of certainty, but there are prodromal criteria, like kind of like we think it is, like middle line criteria. They're just trying to tell you that there's different degrees of certainty and different diagnostic criteria for that. But if we are using the most stringent criteria, the patient needs to be over the age of 30. It's a sporadic disease. We don't have a better explanation for other diseases that could be causing their symptoms. And they must have some kind of autonomic failure, specifically defined by either urinary retention or urinary urgency incontinence or orthostatic hypotension. And the most stringent criteria, the Parkinsonism of the patient either is not very responsive to Sinemet or levodopa, or the patient has a cerebellar phenotype. So that's the MSA patients. There need to be 2 clinical markers that support 1 MRI marker, and we'll just go into what those are. So for example, when I'm in clinic seeing patients for Parkinsonism or what seems to be a degenerative cerebellar type picture, I am thinking about MSA if they are having a rapid progression of symptoms. For example, over the first 3 years or so that they're starting to notice their symptoms, that they are noticing a consistent downward decline, unfortunately. With other diseases, for example, Parkinson's disease, a very slow progression. So this is one red flag that's tipping us off toward this diagnosis. If they're having early falls, early feelings of imbalance, postural, like we do this pull test in clinic, and many of you have probably experienced this, where someone is behind you and yanks you back and will catch you if necessary to test your balance. If that is really abnormal early on, that's unusual and is a red flag for us. People who are having trouble with speech that's not mild, more moderate to severe, or swallowing issues early on in the first 3 years, that should be tipping our little bell off that we may be dealing with an atypical form of Parkinsonism or something like multiple system atrophy. Again, if someone's getting enterocollis, that should be a red flag. People have upgoing toes. You may have been scratched at some point and people are watching your toes. That's a sign of hyperreflexia that can be seen in this disease. Also myoclonus. Most common in MSA is you have patients hold their hands out and you can get these jerky fine I'm not doing a good enough job, but jerky fine movements in the fingers called polymini myoclonus. That's very common in MSA. So we look out for that on exam. And jerky tremor, finger to nose, and kind of more of a jerky pathway. From non-motor, stridor or inspiratory sighs are some of the symptoms that they have decided are on the consensus criteria. Extreme discoloration of hands and feet, that's related to dysautonomia. Erectile dysfunction, obviously alone by itself, is not suggestive of MSA, but can be, is on the non-motor list, and then emotional incontinence. For these MRI markers, let me see if by any chance this laser's working. No. Hope you can see this. This is our classic hot cross bun sign, which simply is shown, it literally looks like a hot cross bun. This is down in section in the pons. So if we're cutting the brain like this, we're in the brain stem. This is the cerebellum. These are the temporal lobes inferiorly of your brain. And then we're looking at the pons in section, and we're seeing degeneration of these connections between the cerebellum and the pons. So they are degenerating. You can see this also right here. This is also a hot cross bun. But like we saw on the pathology before, in gross pathology, we have a withered away, unfortunately, cerebellum here. This is normally big and thick, and these are like little remnants of like a tree almost, I think of it. And then here we have the brain stem. This is our spinal cord down here. This is our brain up here. It's the connection between. And like I said, normally we have this big fat pons. Here we are almost totally flat. So these are some MRI signs that we can see. And then another one that is, we don't see as commonly, but it's definitely something I'm looking for, is called the putamen rim. It's this kind of T2 white colored hyper intense lines here around the putamen. And that is also a degenerative sign associated with MSA. And then, of course, depending on the patient, we don't order adjunctive tests on everybody. Sometimes the diagnosis is real, and this may change over time as diagnostic criteria are being more revised toward biomarkers. So in a year or two, this may be different. But in real clinical practice, I don't order adjunctive scans on every patient. I order them on people who I am not sure. I've got some uncertainty about what's going on. So for example, a DAT scan is a nuclear medicine test. It does not give us a diagnosis, unfortunately. Excuse me. It would be positive and abnormal in patients with Parkinson's and PSP and dementia with Lewy body. So it's not one, if you know that there's a neurodegenerative disease happening, you know, for Parkinson's, it's not going to help you make a diagnosis. But for example, if you have a cerebellar patient and you're trying to figure out, do they have a spinocerebellar ataxia? Is this MSA? And you're not sure, and the imaging's not helping, or it's not really obvious on the clinical history and exam, I'll occasionally order a DAT scan. This is a normal DAT right here, nice comma-shaped imaging here, and then this is abnormal, or we're losing different dopamine transmission here. And then sometimes, I don't often order PET scans actually, but there are different changes in glucose metabolism in the brain with different diseases, many different degenerative diseases. And so someone, if you're really struggling, you might need to order a PET scan, or in the future, when I'm hoping that we have very specific disease modifying therapy and we're trying to confirm a diagnosis, maybe this is something we'll use more. But for example, you're looking here from a normal, this is a Parkinson's scan versus MSA, you're seeing hypometabolism here. In the putamen, it's kind of a like more cool looking color as opposed to the bright red. And you know, there's if there's complexity and your doctor is really not sure, there's things like, we'll talk about later, different CSF biomarkers and skin tests that can look for alpha-synuclein. But most of the time, honestly, we don't need to do that as of right now. And this slide is just to say that there is a lot of overlap between other diseases. So I don't know how many of you in the audience struggled getting your diagnosis, but I want to just let you know that there's a lot of overlap. It's not easy sometimes. So, you know, it can be a very frustrating experience getting to where you are. But there's quite a bit of overlap with atypical Parkinsonism, secondary Parkinson's disease, in particular with MSA. So in terms of how do we manage these motor symptoms, let's turn our focus there. I'm going to go through these one by one. So the most important thing I want you to hear today is that exercise is super important, aerobic exercise. It's really important to move and to work hard with your physical therapist to maintain yourself, whether that is through what you're doing with your gait, but also, you know, just pure aerobic exercise. We want you doing at least 30 minutes a day. Depending on what phase of the disease you're in, like that may vary. You know, if you're early on, you may be able to go for an intense boxing workout or go for a brisk walk. Later on, you may be figuring out what are safe ways to continue exercise. Stationary bike is great. Pedal machines are good. We want you ideally at 80% of your max heart rate, but that's not don't worry about that. I just want you to do it. It really is important, and it slows down the progression of the disease. And it's tough because if you're comparing yourself to a Parkinson's patient, you may not feel that you're doing better, but if you're not doing it, your progression of your disease will be faster. So that's very important. It also encourages social engagement with others, which is really good for your brain. So we encourage you to maintain that. So it's super important. And then I want to introduce to you, which you'll hear more from our other speakers, but your best friend, much more important than your neurologist, is actually your therapist. So that's physical therapy, occupational therapy, and speech therapy. And I want to just give you a brief idea of how they can help you with your disease. So physical therapy, what do they do? Well, they're working on how you walk. They're working on your balance. They're working on posture exercises. They're going to teach you what they think are appropriate home exercise program given your level of ability, wherever you are in the disease. If you're in a phase where you need an assistive device, they are working with you to make sure you have the right one that's safe and going to prevent falls. They are working to make sure you know how to use it and that your family knows how to use it so that you're not falling with it. They can work with you if you have that freezing of gait and you're getting stuck. They can work on different techniques to help you get out of the freeze and not be stuck. And then later on in the disease, they're working on how to get you up safely. Your family or caregiver may need to be working with you on transfers, and that can be really dangerous for everybody if we don't know what we're doing. So your physical therapist is your best friend. Please know them well. If you don't have one, please get one. They're very important. Occupational therapy, OT. It took me a long time to figure out what an occupational therapist was, but I'm happy to say I think I have a handle on it now. Their job really is to make you be as independent and functional as possible. And I know for a lot of my patients, some of the biggest grief in this whole process is the loss of their independence. They're like strong, functional, smart, independent people, and they do not want that to change, which is understandable. So OT are the people that can help you do that. And their philosophy, I think, is that focus on what your strengths are. Like, what can you do? A lot of times we have inside of us, of course, what I'm not doing well, what has changed, this is hard. But what can you do? How can we take advantage of that to allow you to be independent? How can we change things in the environment to allow you to do things like getting dressed, like taking a shower, like going to the bathroom, like maybe even cooking, like eating by yourself? And it sounds trivial, but it's a really big deal. And they are really good at thinking through some very interesting ways to maintain your independence. I have been pretty blown away by our OT, what she comes up with at Kaiser. So very important people. They also think about your fine motor skills, handwriting, hobbies that are important to you. Some of these things may or may not be able to continue as the disease goes on, but they might have some tweaks for you that you haven't thought of. And in some cases, with certain patients, we can also ask them to help figure out how you're doing driving-wise, which can be an issue. And speech therapy, you're gonna hear a lot from Stevie about this, but they are helping with the changes in your voice, helping you learn how to adapt to them. Can you slow down? Can you breathe differently? Different vocal exercises that you can do at home. They are working on the swallowing, both techniques to swallow more safely, as well as if you need to adapt your diet so that you are not choking on different things. They also are trained to help with your cognition. And she'll go much more into this, but they have wonderful experience with how you can use adaptive technologies as the disease is going on to help maintain your speech, whether that's a Tobii Dynavox or many other things that she's going to talk about, and alternative forms of communication that can be used as the disease goes on. From my side, what I'm often doing with patients is trying a medication called carbidopa-levodopa, also known as Sinemet, also known as dopaminergic therapy, okay? And this would be with either an immediate release formulation or a control release formulation. This is more effective in general, in my opinion, in patients with MSA-P, the Parkinsonism variant, but I will try it in MSA-C patients if able. It's a slow titration. We will start with like half a pill 3 times a day and gradually work up to 3 pills 3 times a day if we're able to. There's a lot of complexity, and some of you may not actually be taking this medicine because you may have really bad orthostatic hypotension, and it may not be safe to use it. But when we can, we do want to try the drug, because as many as 20 to 70 MSA patients do get clinical benefits, sometimes so robust that we can get confused into thinking they have Parkinson's the first few years of their disease. But it does have some side effects. You can get lightheaded with it, drop your blood pressure, get tired, rarely more confused or hallucinating, and it can upset your stomach. And with this medicine, you can get some of these involuntary movements in your mouth called dyskinesias. It's very common in this disease. As the disease goes on, it tends to be less effective, but for some of my patients, it can be quite robustly helpful. So it's always good if there's not a contraindication to try the medicine. Amantadine is an anti-dyskinesia medicine, which can be used if you do get dyskinesia. Botox can be tried if you are having that enterocollis, although it hasn't honestly gone that well. It's a very hard to treat symptom. There are no strong medication evidence for medicines for ataxia right now, unfortunately. Of course, you want to make sure the patient doesn't have a vitamin deficiency, which may be making things worse, like vitamin E or B12. Some patients that get more spasticity or spasms with the disease, we can use muscle relaxants, but we have to balance that against their not wanting to be sedated and or not wanting to fall. And disease progression, it is gradual, but it's over a 6 to 10 year period typically. Things start out with a prodrome. It could be loss of your sense of smell, REM behavior disorder where you're acting out your dreams, constipation, etc. And then evolving over time to mild Parkinsonism or mild cerebellar features with progression over time with these things that we've talked about, like falls, slurred speech, changes in voice, and swallowing problems. And then in the late stages of MSA, unfortunately, the orthostatic hypotension may be becoming severe. We may really be struggling with people's blood pressure. I'll leave it to Dr. Miglis, but speech may be getting worse, and the care from your family or in an assisted living type of situation is happening in that later phase. So I know that's a whirlwind tour here, but I just want to end on kind of some hopeful stuff, like what is changing, what could the future hold? If you're reading along with the literature, as many of my patients are, unfortunately, all disease modifying therapy trials have been negative so far. But there was a small phase 3 trial on ubiquinol, which is a form of CoQ10 that suggested it could be helpful. But some directions that, look at kind of the overall field of medicine, like different things that are being tried that, have a lot of hope, are using antisense oligonucleotides. Is very early on, phase 1, very early on in looking at this, but different immunotherapies like monoclonal antibodies to alpha-synuclein is in a phase 2 trial. Stem cells, we have hope for the future. We are not even close to as far along as I would like them to be, but that's an idea that's being looked at. And then if we can get better at diagnosing the disease and diagnosing it early in people in the prodromal phase, that's really going to help us on the research side to try to investigate things that at an early point could help modify the disease and slow it down. And the really exciting stuff coming out of conferences in the literature is that we're coming up with new things to diagnose, whether that's out of the skin, out of the CSF or blood, looking at these alpha-synuclein seed amplification assays. Give me a lot of hope that we will be able to diagnose this more confidently in the future. I want to thank you for your attention and thank our whole team, both at Kaiser. These are our physical therapists and speech therapists and occupational therapists in Santa Clara. And then the big picture is our movement disorder group for all of Kaiser Northern California. Thank you so much for inviting me.
Thank you very much, Dr. Call. If anybody in the room here has a green card, please fill them out for questions or grab your neighbor's green card to fill it out for questions, and people will be coming around. And when I say people, I mean other people will be coming around to pick up green card questions. And if anybody virtually can enter in a question on the chat or the Q&A, that's great too. Get your questions in fast because we don't have very much time. We want to stay on time.
Sorry, I was running a little too long there.
You were good. You were good. We were very happy. Thank you, Dr. Call. Yeah, so I have a couple of questions. One is PISA syndrome more common in MSA than in Parkinson's disease? Or is it just more likely to be seen sooner in MSA?
I don't know if I have an actual answer to that. I would say that postural problems in general are more likely to be seen sooner in MSA. And I don't see PISA often, but I do have multiple patients with it, most of whom happen to have Parkinson's because it's just a much more common disease. I'm not sure if I have an exact answer to that.
Okay. I don't know is a perfectly good answer. We thank you for that. Okay, I think this is more of a comment. It's important to let Medicare or other insurance know how important going to PT, OT, speech therapy are when dealing with a chronic disease. Do you have
Yes.
problems at all with insurance getting approval?
Oh my God, that's why I love practicing at Kaiser. But I would think with Medicare that we wouldn't have an issue. But all of our stuff is internal. So it's
At
easy as
Kaiser?
a click. I send it. I know all of our therapists, and it really is important to have a really strong relationship, which I really am lucky to have.
Yeah, great.
Because I genuinely believe this. They are your most important people.
Okay, we have a couple of local people in Kaiser. Would you recommend that we ask for a referral to see you, Dr. Call?
If you have multiple system atrophy, yes, but I'm sure we have the whole Bay Area coming. So
We have everybody.
yeah, let me just explain our system a little bit. So I am one, if you can see this picture here of all these happy smiling folks. So I'm one of 9 currently movement disorder specialists for Kaiser in the entire Northern California region. We have a 10th one coming on board this year, yay, in Oakland. But we have people, so I cover the South Bay. So that includes like Santa Cruz, San Jose, Santa Clara. I also cover Redwood City and even South San Francisco. So I have a huge territory. So if you're in there, yes, please ask your neurologist to come see me. I am going to be Santa Clara based long term. So if you're closer in that South San Francisco, we actually have a wonderful doctor, Dr. Ash, who's UCSF trained up in San Francisco. We have Suketu Kandar and Miguel Rubalcaba. Dr. Kandar trained at UCSF and Dr. Rubalcaba was at UC Davis. They're both in Sacramento. We have Dr. Divya Call, the other Dr. Call in Walnut Creek. She trained the year after me at Stanford. We have Dr. Jessica Weinstein in Walnut Creek in Antioch. She is UCSF trained. We've got Dr. Han Lee in San Leandro, who is from USC. Wonderful. He's also EMG fellowship trained, so is really great at doing dystonia injections. Who am I missing? Oh, and Dr. Surisha Nandipati in San Rafael, who trained at UCSD, who is trained under Irene Littman, who is one of the gurus of atypical Parkinsonism. We have a really wonderful group. So wherever you live, you ask your neurologist for a referral to your regional movement disorder specialist. They're all wonderful. I literally saw all of them yesterday at our regional meeting discussing patient care. They're all really good.
Great. And if anybody is in the Northern California or Central California and needs a referral outside of, or a name at least outside of Kaiser, they're welcome to contact us and
Yes.
be happy to direct people accordingly.
Absolutely.
Okay, we have a lot of questions about imaging. I'm going to read a couple of them and maybe you can figure out if there's some common thread here. At what point in the progression would an MRI be able to confirm a diagnosis of MSA? And then a similar, a little bit more complicated question is, a DAT scan showed synuclein deposit suggesting MSA. MRI was normal in the pons and cerebellum. Can cerebellar atrophy occur after alpha-synuclein deposits?
All right, let's go through those one by one.
Okay.
You know, I think that, so first of all, when you initially present to your doctor, if you have Parkinsonism at all, they're going to get an MRI of the brain unless you have some reason you can't get one. And let's say you do have MSA and we don't know that diagnosis yet. You could have a normal MRI initially, maybe. And that does happen. And over time, maybe some of these signs show up. It might not be as obvious as a hot cross bun, but it could be that your pons and cerebellum are subtly getting more atrophied or smaller over time. So sometimes it is the MRI doesn't make the diagnosis, it's a part of the diagnostic criteria. So your doctor is looking at you clinically. What symptoms do you have? What does your exam show? What did the MRI show? And weighing that against the diagnostic criteria. And for many people in the first 3 years of presentation, let's say there's some kind of an atypical Parkinsonism, it's not defined enough to make the diagnosis. So, and that leads to a lot of grief for people. So I'll have people go, hey, she doesn't know what she's doing. She didn't give me my diagnosis. But they might have, it might not be clear. Is this PSP? Is this corticobasal? Is this MSA, or even dementia with Lewy body? Sometimes it's really obvious, and sometimes people have features of 3 of them, and you can't tell from the MRI, so you have to follow them over time. And I'm very direct with my patients. If I can't make a diagnosis, I just can't, and it takes time, and it will become more obvious usually over time. What was the second question, Robin?
Oh, it's complicated. So maybe let's take it offline.
I would say the DAT, you have to make sure whoever's reading the DAT knows what they're doing, because sometimes they're not read correctly. But there are false positives and negatives off of a DAT scan. So about 5% rate. And you really start with clinically what's going on, because sometimes you order a test, and if you get a false positive or negative, boy, the patient gets really lost. This happens a lot in Parkinson's. They have a normal DAT scan, and their first neurologist is like, oh, you don't have Parkinson's, I don't know what to do. They come to me, I'm like, yeah, you have Parkinson's, this is pretty obvious. And if you don't have an abnormal DAT, well, shoot, you must be a false negative. So anyway, it's much more complex than just one test. It's really taking everything as a whole.
Okay, and a couple quick questions. What is emotional incontinence?
Yeah, so that honestly, I don't quite know either. I was reading the diagnostic criteria. So I'm thinking what they mean is that you are having an emotional overflow, or perhaps something along the lines of pseudobulbar affect. I don't know. Do you know, Dr. Joe, what they mean by that?
I can answer that.
Yeah, I was reading, I was like,
yeah, like bladder incontinence is the inability to, just as you said, to hold in your emotions. And oftentimes people with emotional incontinence cry for seemingly no apparent reason, or laugh.
I guess pseudobulbar affect type stuff.
Yes,
so exactly. Yeah, you might not actually feel sad or happy, and you're crying or laughing, so normally when we cry or laugh, we feel those emotions and they're congruent. So sometimes it's a discongruence, and you're just like, I don't even know why I'm doing this.
How are we on time, or are we
By the
1
way,
minute,
or seen in other diseases?
1.5 minutes. Okay, thank you. Okay, very good. Thank you. Let's see. My husband was diagnosed recently, or in 2009, but seems to be progressing very slowly. What should I do in this case? Should I consider another opinion, or what should I do?
I would. I think it would be highly unusual to have gone that long for MSA. Not that it's impossible, but I would get another opinion, yes. Although I can't, that's a general statement, but yes, I think a second opinion would be good.
Okay, do we have time for one more? 30 seconds. Okay, I'll do a fast one. How about treating excess saliva? I think you mentioned Botox.
Yeah, absolutely. So it depends on how bad it is. If it's mild, you can use atropine drops under the tongue, or Robenol, like a Pirilet swallowed. But I actually, if people are drooling out and they're wearing a napkin or a bib or something, I just Botox them with MyoBlock. So these are Botox injections they're really easy, that just right under the skin here, 4 shots. They do burn, but they work. Yeah, ask your neurologist for MyoBlock injections.
Dr. Call, thank you very much.
Thank
Fantastic
you.
presentation.